So hello everyone, and my name is Dr. Mosfe Christina. We're going to talk about management of osteoporotic fractures. And today we've done a role play where it is management, like follow-up. How do you follow up a patient who has confirmed osteoporosis? So a DEXA scan has been done and it shows that the patient has the diagnosis. What we talk about today is also applicable to if the patient is coming for the first time and a DEXA hasn't been done. The underlying principle is that you are assessing fragility fractures. You're asking for risk factors. You're asking for, bear with me 1 second. You're asking for risk factors. You're asking for lifestyle of the patient, because fragility fractures affect people differently. If somebody has an active lifestyle and they're at risk of fragility fracture, you can imagine the fear. And I've actually had a case like that where a lady says, I gained weight because I had osteopenia and I was worried about fracture. So she stopped going to the gym, compared to somebody who is active, but they didn't have that fear, but they didn't have a fracture. So apart from assessing fragility fracture, our clinical management needs to be relevant to the patient and their lifestyle. So if you're not assessing the patient's lifestyle around fragility fractures, you will not be able to give patient-centered management to the patient. So one case of fragility fracture would present differently or affect people differently. I once had a case of a lady who declined medication, and when I was speaking to her and she accepted to start the medication, she walked into my GP practice 6 months later and she said, I wanted to show you the difference you have made just by giving me good advice and giving me advice that works for me. And that was a lady who didn't want medication. She had experienced so many fractures. And rather than me just telling her, do you want to go to the gym? I now explained that because you have so much fractures and you're struggling, you're bedbound, I would like to refer you to physiotherapy, and I would like to not just any physiotherapy, it has to be community physiotherapy for home visits and regular physiotherapy at home. And that was how she started her healing journey. And 6 months later, when she was booked in, I was like, oh, I know this name, I know this patient. She walked in, and when I realized, oh, this was my patient, she walked in with a walking stick and said, I wanted to show you just how thankful I am. And that just gives you an idea why your management, your advice needs to be very patient focused, needs to be centered around the life of a patient. So when we see osteoporotic fractures, what are we meant to be doing in that case? We all know that our consultation structure is meant to have eyes, PSO, check for impact, and assess the patient's ability to perform their daily life and daily activities. So going shopping, walking, driving. And osteoporosis is a musculoskeletal case. And if you look in the portal, there's a video on musculoskeletal case. How do you assess for impact in musculoskeletal cases? Rather than assess how is this affecting your daily life, how is this impacting on you, which is very formulaic, go straight down and assess the function of that limb. So if a patient is saying, I've got back pain, and you know that back pain is going to affect their walking, their driving, go straight away and assess. So since you have this back pain, are you able to walk around the house? Are you able to go out and do your shopping? Have you been able to drive? That's you assessing for impact without using the word impact. So musculoskeletal cases, as part of our consultation structure, there are ways we move things around to show the skills or to show that we are able to adapt our communication skills. But let's say a patient is coming in with a new symptom. A new presentation, you have to ask your symptoms around that presentation. So for example, back pain, which can be a wedge fracture, which is very common in osteoporotic cases. Or even if it's a follow-up and the patient says, oh, yeah, since the last time I had my DEXA, I've been having back pain. You then still need to ask your Socrates questions, just the way you would ask your Socrates question if it was a new presentation. It's the same way you ask your Socrates question if the patient was coming up for a follow-up. And because we've done a follow-up today, I might be using that follow-up a bit. You've got to ask patients things like, oh, I've got your DEXA scan here. What do you know about the scan? Do you know what the scan is testing for? These are the ways we check for ideas when we're doing a follow-up case. And if it's a follow-up where the patient have had a scan before and you are not seeing the patient, it's important to ask the patient if there have been any fractures in the last 5 years, knowing that it's 5-year interval between DEXA scans. So in cases like this, I would ask this lady if she's had any broken bones, if she's had any back pain, or if she's currently having back pain, because that could indicate she may have wedge fracture. He or she, the patient, might have wedge fracture and may need an X-ray. But sometimes the diagnosis of osteopenia or a diagnosis of osteoporosis in the past can affect the patient lifestyle, where the patient might become afraid to exercise, go on holidays, or do any high intensity activity because they have been told they have osteoporosis, the bone is thin, and they are not afraid to exercise. So patient might, as part of the impact, you may want to ask them, since you had the scan, how have you been? What do you think about this? And patient might even disclose to you and say, actually, since I had the scan, I've been afraid to do A, B, and C because I'm afraid of having a fracture. And that's you assessing the impact of a diagnosis in cases like osteoporosis. And as part of our data gathering, we need to be showing the examiner that we are assessing the risk factors around that patient's life. So on ICKS, there are loads of risk factors that we need to be aware of that could cause osteoporosis or make osteoporosis worse. So look at the lady's age, if it's a man, this age, or any history of fragility fractures, so especially that maternal history, which our doctor did today, nicely asked. But apart from that, you also need to be looking at the patient's comorbidities, because as part of your clinical management, you need to be managing comorbidities in this case. Assuming that this was a case of osteoporosis, but this patient has COPD and the patient has a lot of exacerbation and a lot of steroid use. So if you're asking me, oh, have you been using a lot of steroids? Patient may be like, I don't know, I don't count it. Or patient may not even be aware that steroids have this much impact and side effect on their health. So if you're asking the patient, have you been having a lot of steroids? Patient might just tell you, I'm not sure, doctor, I don't know. But what's a better way to assess that? You might use the doctor's notes to say, I see your records, you've got COPD. How have your symptoms been? Have your COPD been well controlled? Have you had a lot of exacerbation in the last 12 months? Because patient with a lot of exacerbation of COPD in the last 12 months, they need to be referred to their COPD nurse for review of medication or for pulmonary rehab. So you can imagine that if you are picking up a case like that with a lot of exacerbation, you need to be managing comorbidities in that case. But sometimes, especially in ladies, we need to be mindful that premature menopause. So you have a 30-something-year-old, we've done as role play today. I probably have asked her signpost that there was sensitive questions to ask, but then I would have asked her, how is her monthlies? Is it regular? Because you want to assess whether this lady has had premature ovarian insufficiency, premature ovarian failure that could cause osteoporosis. Or what if she's had cancer? She's been on tamoxifen and now she's on having osteoporosis. And these are real life cases we see. But patient is not going to come tell you, oh, doctor, I think it's my tamoxifen. You ask the GP expert. You are meant to be looking for the risk factors in cases like that. Sometimes I've actually seen this in real life in hospital rotation where it was a teenager with low BMI who was admitted for eating disorder and also had osteoporosis. So we always need to know the risk factors and look at the case and say, okay, what's missing in that doctor's record? There's no BMI in this record. Part of your clinical management, your data gathering, you have to ask this lady whether her weight has been stable. Have she tried to lose weight? And if you're picking up low BMI or eating disorder, extra comorbidities to ask as well. But medication, especially contraception, is one of the things we miss in our risk factors, especially in ladies. So it's important that we are asking for medication, not just asking, do you take any medication over the counter and then you move on? You've got to look in the doctor's note. What medication is in the doctor's notes that could act as a risk factor to cause or worsen osteoporosis or worsen osteopenia in a case which we have done today? So when we've collected our data gathering, we've now have to let the patient know what the diagnosis is. So, but again, with health communication, patients want to know what's happened, why did it happen, what can we do going forward. So your robust data gathering needs to show the examiner you're working. So marking scheme, according to the 14 fish says, verbalizes diagnosis and all analysis to the patient. So our patient's name today was, let's say, Alicia. So Alicia, I'm really sorry that your DEXA scan has shown that the bones are more thinner. It's gone worse than the last DEXA you had 5 years ago. And when this happens, we actually call this osteoporosis, which just means thin bones. Based on what we've talked about and looking at your records, I believe that there hasn't been any improvement because you've been on Depo-Provera every 3 months and you're also on sodium valproate. And these are medications that could make osteoporosis worse. So you're verbalizing the rationale and identifying the risk factors to the patient and to the examiner why certain things have happened. So the first point here is to explain osteoporosis and then the risk factors that led to it. Talk about why we need to prevent things from getting worse, or to manage the patient and reduce the risk of things getting worse, and preventing fractures in the future. Now, depending on that case, if it's a new presentation, you have to explain why the patient needs to go for a DEXA. So a new presentation and you are suspecting osteoporosis, you've got to explain that DEXA scan and the bloods and all the things you need to be doing. But in the case we've done today was a result case where the patient already had DEXA. Explaining the DEXA scan is irrelevant in that context. So again, this is the adaptability and you knowing the points that you need to cover in your management, but which one are you going to use going forward? And of course, address the patient's agenda first. So if it's a role play, result case, patient wants to know what the result is. You have to explain that diagnosis first before you move into your other management. One of the common pitfalls we see is doctors talk about the medication, but they just say something baseline or shallow by saying, oh, there is a medication that we can give to do A, B, and C, and they just move on. But if you look on ICKS in the medication for allergenic, there is a MHRA summary warning to all doctors that there is a high incidence of esophagitis from allergenic acid because of poor explanation. And this was again flagged up, I think, 2-3 years ago, and a warning was disseminated all over the UK saying this is a big problem. People need to be explaining things more. So knowing that, if you see a case of allergenic acid and you are not giving robust explanation, in real life, you are opening up yourself to medical legal litigation. In the exams, you will struggle to get marks in that case. And when you offer biphosphonate in cases like this, you really need to negotiate with the patient. So patient, you may tell the patient, oh, there's a medication called allergenic acid that we can use to strengthen your bones and prevent this from getting worse. There are 2 ways that you can have this medication. The first option is that you can have 10 milligrams of this tablet every single day, and you can take it with your regular medication. Sorry, I didn't say that right. Not with regular medication. Sorry for that. So I can say something like, we can prescribe you allergenic acid. And the first option is that we can prescribe you 10 milligrams, which you can take every day, and I will explain how to take it shortly. The second option is that we can give you the total dose of 70 milligrams to take once a week. What would you prefer? And then you allow the patient pick the one they want. Then I can go into explain each of and then explain a bit more about the medication. So since you've chosen to take this every day, which day would you prefer? So patient might pick Monday or Wednesdays or Sundays. Oh, I would prefer to take it on Sundays before going to church. Why is that important? Because the advice in medication like this is that when patients are going to take infrequent medication, so a medication that is not every day, we should help them tie it to something. So if you have a patient who is non-compliant with medication, empower them to link that medication to an action that they do every day. So let's say a patient says, oh, doctor, I'm really bad at taking statins. I always forget in the morning. A way I can empower that patient to take that statin can be, what do you think about taking the medication in the morning immediately after brushing your teeth? That way you know you've taken your medication for then you're done. So that's me getting the patient to link taking his medication to an activity they do every day, so that immediately they brush their teeth, they know, okay, my mind is my medication next. So a patient may choose to put that medication on their sink counter or their drug cabinet right by their toothbrush, and that creates a mental link. And when patients complain about compliance, that's the way we can empower them to improve compliance in medication. So the same thing goes here. If a patient says, oh, I'm going to take my 70 milligram once a week, you are meant to try and empower them to take that medication. So, okay, I'm going to take it on Sundays. Oh, that's really great that you've picked a day. What do you think about taking it or just after something you're familiar with, so that you don't forget your medication? You have to try and have that robust conversation with the patient, as well as explaining how to take the dose. So first thing in the morning, measure the glasses of water they're taking, and to sit upright for at least 30 minutes after taking the medication. So when it comes to explaining osteoporosis allergenic medication, it's very complex, and it's something you have to practice to form your own style in how to explain allergenic, because different people do it in different ways. For me, I tend to break it down in four checklists, which I have done here, where I explain the medication. I ask the patient if they check understanding, if they would like to ask any questions. Do they understand me so far? Do they want me to explain it again? Then I empower them to pick a day. And then I say, okay, so now that we're going to start this medication for you, I want to talk about some side effects. This medication is usually tolerated by everybody, but sometimes some people have a bit of stomach upset, nausea, and vomiting with this medication. And in order to help, I can prescribe you another tablet called lansoprazole to protect your stomach while taking this medication. But if you find that you're not able to tolerate the medication, would you be happy to give me a call? So I've used action words, taking ownership, give me a call, not call back. We don't want those vague words. So would you be happy to give us a call or give me a call, so that we can switch you to another type called risogenic acid? And if we find that you still cannot tolerate that medication, we can refer you to the rheumatology specialist, because they can give you this medication through your veins. Now, what I have done there with that last point is that I've shown the examiner, I've empowered the patient, yes, but I have shown the examiner that I know my step 2 and my step 3 in case the patient doesn't tolerate the medication, as well as protecting this patient. So other things we need to do according to ICKS is that we need to talk about calcium levels. So a patient comes in, talk to them, and we need to do your bloods, we need to check your calcium level. Then you explain again, what will you do if that calcium is normal? So if we check your blood and your calcium is okay, my advice would be that you continue with the vitamins that you've already been taking, according to our role play where the patient has already been taking it. But if we find that your calcium levels are low or your vitamin D levels are normal, I'm happy to prescribe you medications because we need to bring your levels to normal. So you have to explain your step 2, step 3, in case the medication, the blood test is abnormal. Then you can go into other lifestyle things that needs to be done for that patient. So if you identify that this patient is has alcohol or smoking in their history, you're addressing that. You talk about exercise, using conversational words like, I usually recommend that we build your muscles by going to the gym. I'm not saying strength. We usually advise you to have strength-based exercise. That's very academic. And if you're having a patient with learning disability, that might be a challenge for the patient. So you've got to bring it down to exercise and conversational level about exercise, and of course, maintain a healthy diet. Now, many doctors stop here in lifestyle, move into PIL and follow-up. But again, other points that is missed is that we need to tell patients that the DEXA needs to be repeated in 5 years' time until that osteoporosis is corrected. Every 5 years, they need to have a repeat DEXA scan. And we need to always think in our case, who else needs to be involved? So in a case like this, mandatory, and if you're putting patients on electronic and you don't have this conversation and you don't document, you expose yourself to medical legal problems. It's mandated that we tell patients to inform their dentist to put them on a list for regular checkup for jaw osteonecrosis. This is another MHRA warning. Some doctors might say, oh, because we're putting you on this medication, we want your dentist to be aware because the medication can affect the jaw and cause the bone to break down. So what I'm happy to do is write a letter, which you can pick up a reception and you can share that letter with your dentist. Would you be happy with that? So some doctors might offer a letter to support the patient to inform their dentist. Some doctors might just verbalize to say, we want you to inform your dentist. Are you happy to inform the dentist, or would you like me to write a letter about this? Again, giving patient options and allowing them choose what they would like their care to be. Now, if you're identifying that this patient has an active lifestyle, and this is where your patient-centeredness comes in, you've got to give lifestyle advice relating to that patient's lifestyle. So let's say a lady has osteoporosis, but she's a fitness enthusiast, she's always exercising, or she does boxing. So you can imagine that her lifestyle and that risk of boxing with fracture is going to be very high. You now have to relate your advice to the lifestyle of the patient. So let's say the patient is dancing and she's worried that it will affect her dancing. You have to say, I know you mentioned earlier that you love dancing, and I'm glad that you have that hobby with your partner. But because of the osteoporosis, we just want you to be a bit more careful so that you don't have fractures. And if at any time you notice A, B, and C, and X, Y, and Z, you're not giving her safety netting around that dancing. Because if she goes now and starts dancing, let's twist again, like we did last summer, and she's twisting her back with osteoporosis, and then she gets back pain. Where do you think that would lead to? She's got a wedge fracture. So you have to empower her with information that's relevant to her lifestyle. I hope nobody's laughing at my singing right there. So we've got to empower patients and give them advice based on their lifestyle. And you can imagine why your PSO question is important. It's not just enough to ask who is at home with you. What do you do? You have to ask the patient about what they do for hobby, because hobby, when it comes to osteoporosis, is very important. So here are the things that the examiners would like to see in the management of osteoporosis. The points to cover in your clinical management is a lot. So consultation flow is very important. Knowing that you have a case of osteoporosis, you have to pick up the pace, but with relevance to the patient, because if you've seen an elderly patient or with learning disability, you still have to maintain a flow that you don't seem rushed in your consultation. But if you're reaching your clinical management and you realize that, okay, time's gone, know when to benchmark certain things for another time and the important things to cover. For me, the top points are the ones, so I've prioritized my consultation that these top points, I must cover them because I need my patient to do bloods, and I cannot start my patient on electronic without giving them that robust information and giving them a patient information leaflet. It's not enough to just say, I want to send you information from where. So again, the examination tactic, communication advice is state the patient information source. So Royal Osteoporosis Society. There's a website called Royal Osteoporosis Society that has a lot of information on osteoporosis. I would like to send you information leaflet from this website. It covers a lot of the things that we have talked about, but in that website as well, there is extra information on how to live an active life though you have osteoporosis. What I've done there is I've stated the source of the website. I have stated what I want the patient to read about. So a lot of information we've covered so that she can go and read and get that extra information. I've added an extra benefit in relation to the patient's case. In this case, I'm focusing on her lifestyle. But what if she's focusing on work, or she's focusing on going to the gym or something? You have to relate it to her lifestyle or her concerns, because you are being patient-centered. Now we have a question that's asking, do we need to anticipate and ask questions in data gathering as per side effects of biphosphonate? To that, I would say yes, but relating to dyspepsia, some doctors might choose to ask for dental check. I've actually heard a consultation where the doctor did. But your question now relates to medication safety. And going back to the examination tactic, where if you are picking up that, oh, I need to give this patient a certain medication, I need to make sure it's safe for the patient. And in this case, where you know allergenic acid can cause dyspepsia, it's all right to ask if the patient has dyspepsia. And that way, you are then, relating it to your clinical management. So earlier when you mentioned you've got dyspepsia, and you mentioned that your symptoms have been okay, you haven't had any problems. I'm happy to prescribe you allergenic acid, but I would like to also give you a medication called lansoprazole to prevent you from having new episodes of dyspepsia. Have you noticed the way I've tweaked my communication just because I've got that history of dyspepsia from my data gathering, and now in my clinical management, I'm changing that. If you choose to ask for dental check, that's fine. You can, but your clinical management, you have to show that there was a reason you asked for dental check. So if I ask for dental check in my data gathering, my clinical management, I may say something like, earlier on, you mentioned that you didn't have any dental problems. That's all great. But I would like you to still see your dentist so that he can give you a check over and he's aware that we are starting you on this medication. Would you be happy to give your dentist a call, or would you like me to write a letter so that you can share that letter with your dentist? And then you're now empowering the patient to choose what they would like. Because if you give a patient advice, I want you to see your dentist, the patient goes like, I don't have any problem. If the problem comes, I will go see my dentist. Then you've missed an opportunity for health promotion there, that she needs a dental check, because you need to document first that everything was okay before she starts allergenic. So you need to give that robust explanation. Next question says, in real exam, how can I go about things if I actually forget the name of the drug? Good question, Doc. So there is no perfect consultation. There is no perfect GP. In the exams, we want to bring our best foot forward. But if you find that you forgot the name of the drug, you can recover by saying, at the moment, the drug has slipped my mind. What I would like to do is get the name of the drug at the end of the consultation, and I can give you a call back to talk a bit more about the medication. So what I can do in that situation is take ownership for my learning. Because if you don't remember something and you say, well, I'm not going to talk about it, I'm not going to let them know that I forgot, you are losing marks right there. So you've got to find a way to recover from that by saying something like, the medication doesn't come to mind at the moment, but I would like to go and have a read. I'll have to do A, B, and C, and then I'm happy to give you a call again. So you create an action plan and take ownership. And this happens a lot. Whether you don't know the medication or patient asks you a question, oh, doctor, I've got A, B, and C. Can I travel to Spain for holiday, though I have this diagnosis? And if you don't know and you need expert advice on that matter, what you can do is to say, oh, I'm not aware of any regulation that prevents you from traveling with this diagnosis. But what I can do right now is speak to the specialist in the hospital, A, B, and C, and X, Y, and Z, and I'm happy to give you a call in A, B, and C, give a time frame to update you on what they have advised. So some doctors might say, oh, I'm not sure what we should be doing at the moment. I think it'll be good for me to get some advice and guidance from the specialist doctor on the best way forward. It might take about 2 days to hear back from them. Would you be happy for me to give you a telephone call after I've heard from the specialist? So that's an examination tactic you do, because sometimes you have to get advice and guidance and you need to show the examiner that you're using every available resource to optimize patient care. So you can use those kind of phrases to recover if you are struggling to say a word, or if they've asked you a specialist question and you don't know and you need to get advice and guidance. For example, in hyperthyroidism, so the thyroid hormones is high, so hyperthyroidism. Depending on your area, please check your local pathway, because I know it differs. In my area, we are allowed to put the patient on carbimazole, but we need to send advice and guidance, and we also need to do a referral to get an appointment. So some doctors might say, oh, we need to put you on a medication called carbimazole, but before I start the medication, I would like to inform the specialist endocrinologist in the hospital to let them know that this is your diagnosis, and if they're okay with this, I'll prescribe the medication for you. Would you be happy for me to give you a call back tomorrow so that we can talk about this medication in more details? Then doctor might follow up by saying, oh, while I seek this advice from them, I'll also put a full referral so that they can see you in the clinic for your appointment. So you find your own phrase to explain things like that. That's the way I do hyperthyroidism in my area, because we are allowed to get advice and guidance, put patient on carbimazole, but we need to do that formal referral for an appointment. So what I do in real life, and my supervisor taught me that to save time, when I'm seeking advice and guidance, I write him advice and guidance and say, oh, patient has A, B, and C diagnosis. Patient is happy to attend appointment. That way, let them convert my advice and guidance to a referral. Sometimes some mean GP consultants will bounce it back. Sometimes we get a reply to the advice and guidance, and then in the reply they will say, this has been forwarded to the secretary. Appointment will be scheduled. So one letter sorts everything for me. You have to find your way to manage your workload than doing 2 letters. Copy and paste, it works anyway. But that's a tactic my ES back then told me of how to use my advice and guidance to also get an appointment. So this advice and guidance, I need A, B, and C advice. However, patient needs an appointment. Patient is happy to attend if A and G is converted. I just find a nice way to write it. So another question here says, wondering why lansoprazole will be daily if patient opts for hyaluronic acid. PPI is a daily prescription, because if patient opts for weekly hyaluronic, it takes a week for that medication to wash out of the system. So she's taking it for that day, but the effects are still ongoing for a week. So I'm happy to be updated. Check the lifestyle, but I know lansoprazole is meant to be daily, even though the hyaluronic is a weekly prescription.